around the world. I have a case that will start as unknown, but I think many of you will get to it. But it is something that we here, at least in the United States, are beginning to talk a lot about. So this is a 54-year-old woman who was seen by a general ophthalmologist first for her complaints of central scotoma, metamorphopsia, and yet she had 20/20 vision. And at that time, she was diagnosed with dry macular degeneration. But because of her symptoms that were not correlating to her retinal findings, she was seen by a neuro-ophthalmologist, and she was at that time complaining of enlarging blind spot. But then the neuro-ophthalmologist saw the retinal findings and then said, something's not right. So she comes to me. Well, this is what I saw when I saw her first. There was definitely areas of what appeared to be a geographic atrophy with drusen-like deposits, yellowish deposits. And it's very interesting that it's somewhat symmetric in both eyes. And there was also peripapillary atrophy in both eyes. And this is the OCT finding. You do see the areas of atrophy perifoveally, but the fovea itself is spared. So perhaps that's why she has 20/20 vision. But some of you might say, oh, wow, that sort of looks like the flying saucer sign that we sometimes see in certain conditions. So you sort of keep that in mind. And then this is fluorescein angiogram. So mostly a staining defect. Nothing was really leaking per se. This is autofluorescence, fundus autofluorescence, which I thought was quite striking. Those large areas of atrophy, hypoautofluorescent. But then this hyperautofluorescence was pretty much throughout the posterior pole, and it was very confined to posterior pole only. And indeed, she did have areas of visual field defect pericentrally. Her complaints of scotoma were validated. So what's going on here? So,
Judy,
yes.
I think it's really interesting when you go back to the autofluorescence. If there weren't those areas of geographic atrophy, you would think this was a pattern dystrophy. And, maybe not exudative AMD, but some sort of dry AMD mimicker without those big atrophic areas. I would say, oh, this is a pattern dystrophy, and I would ask about a family history. But the one thing that you pointed out that is really interesting is when we see something like a pattern dystrophy or something genetic, both eyes are usually mirror images. They're very, very symmetric. And these are actually, they're not mirror images. They have the same pattern in each eye with a spot up to the right and a spot down to the left, which is kind of atypical, I think.
Yes, so I think that's what many of these eyes were initially diagnosed pattern dystrophy. Many of them are seen in inherited retinal degeneration clinics as a result, just as Carolyn said. So this patient has pentosan polysulfate sodium associated pigmented maculopathy. And these patients have interstitial cystitis, and she herself had been on PPS for 15 years. So what is PPS, or Elmiron? It's a trade name. It's a second-line oral therapy for interstitial cystitis, or otherwise it's known as painful bladder syndrome. These patients have urinary urgency. Sometimes they have to go 30, 40 times a day, and it's very painful and affects more than 1 million people, at least here in the United States. I don't know what this amount is around the world. And the drug, the medication, is analog of biologic glycose aminoglycans and binds to bladder epithelium. And it may be, people are thinking, that binds to RPE, retinal pigment epithelium, and causing toxicity. It was first used in 1980s and FDA approved in 1996. The usual dose is 100 milligrams 3 times a day, so 300 milligrams a day. But I've been seeing a lot of these patients have been on it for 600 to 800 milligrams a day. So the amount that's being used is not always uniform. There are some, but the eye problem has not been noted until 2018, very recently, by Dr. Jain at Emory. He saw 6 patients in his IRD clinic that had commonality, and that was pantosine polysulfate sodium. And then others reported as well, but this first one, median age of these women were 60 years old, but as young as 37. Median duration was 186 months, and there were alterations in RPE and photoreceptor. And as Carolyn said, many were misdiagnosed as pattern dystrophy, dry AMD, or other inherited retinal degeneration. And I had one patient I just saw the other day was even diagnosed with North Carolina macular dystrophy, and I had even genetic testing done. And then there was a larger series with 35 patients from a multi-center study. And the median duration of PPS in this series was 15 years, median exposure 1,661 grams. Median age, again, ranges quite a bit, 37 to 79% years old. And I think multimodal imaging helps to document and also to diagnose. Color, I don't find as much helpful, but OCT does help. And these areas of atrophy are noted. And as I said, there can be flying saucer sign that we sometimes think of as plaquenil toxicity, but this also can occur in this condition as well. But I find the fundus autofluorescence to be most helpful, these patterns of hyper and hypoautofluorescence. And we can see that they can progress over time, and it's quite striking. And even after cessation of medication, it can progress. So I think it's very important that we diagnose them early before significant toxicity has occurred. So I present to you PPS-associated pigmentary maculopathy. It's a newly diagnosed that we should know, and maybe dose-related, maybe duration-related, but more needs to be studied. And I think the best way to diagnose is taking a good history, what medication, instead of just going straight to the eye, we should actually sit and ask the questions. And and even if they're not taking Almiron at the time, they may have taken it in the past. So I think it's very important that we actually recognize these patterns and then take good history. Thank you. Happy to entertain any comments.
Very nice.
I have a quick comment for you. So this is so important, and we've had some patients who actually haven't wanted to get off the medication because they really need this medicine. But in your community, have you notified the urologist or the internist about this potential side effect?
Yes, so I've sent to my hospital urologists and gyno-urologists who handle many of these patients. So they know that I'm interested. We haven't gotten to the point of actually making a screening mandate yet, but the word is getting out. And one patient actually came from a pharmacist because the pharmacist knew about this potential association. And there is a huge internet website about this potential Almiron toxicity among the IC patients. They have their own support group website. So
okay, I'm actually already in the link further. I had another webinar. I came early, and I'm sitting.
Dr. Jay, I would like to have a comment to Dr. Judy. Thanks,
hi.
Thanks, Doctor.
I'm trying to mute Dr. Natarajan.
I'm here. I'm in the.
Jay, you mute.
I'm not unable to mute him.
Nati, can you please mute yourself?
Take your time, sir.
Right.
He's busy talking.
Yeah. Okay. Carry on.
Yeah, Dr. Judy,
Sorry.
Thank you very much for sharing a good case, and it was a learning experience. I have a doubt. In your cases, the geographic kind of atrophy was very evident, but I couldn't see the typically described pigment spots or pigment clumps and the subretinal yellowish spots, interspread subretinal yellowish spot in the case, and also the pigment clumps or spots were also missing. Is it because it was a more advanced case that these findings are not seen very well?
So the color fundus photograph is not always best, as you know. And sometimes certain cameras pick it up better than the others. So the pigmentary changes are actually quite mild. Even though we call it pigmentary maculopathy, it's actually quite subtle. And then the OCT findings, it's actually, you do see some of that here, not only the atrophy, but at the edge, you could see some of these deposits between the photoreceptor and RP layer. So it's actually on top of the RP layer, or within, actually that definitely above the Brooks membrane layer. So I think they do, and they look different than drusen, where it's within the Brooks membrane. So if you look at abnormalities right above the Brooks membrane and RPE. And that's usually where the earlier cases you have.
Yeah, probably your OCT shows those focal, thickening of the RP nodular thickening, but I couldn't see those pigments on the classically shown in the literature. Probably, I know that this causal association is not yet sorted. The between the pentosan and the maculopathy, there is some confusion and about whether it is actually the causative agent. But when I saw that there is like a number of years as well as like 7 years exposure showed some 40% incidence of this maculopathy, and the dosage also higher. The dosage 1500 gram per day had higher incidence of this maculopathy. So probably we have a causal association. Maybe larger studies would show whether it is really a causative, but then I found that there is some confusion about whether it is really a causative agent in this maculopathy. What do you say?
Yeah, I do think there is still a controversy, and I think we do need to study more. The important thing is that when we see the autofluorescence finding, which I think actually is the most helpful of the imaging that we do for this condition, that we ask. And it is a very difficult conversation that we have to have with the patient. You know, they suffer quite a bit, and to tell them that you may have to stop this medication for the sake of not going blind, you know, it's always a risk-benefit ratio discussion, right? So it is a very difficult discussion to have, just like we have with plaque renal patients. The fact that these can continue to progress, and I've seen a patient that progress over 6 months, sometimes it can progress quite rapidly depending on the stage of the toxicity, that we may be able to prevent them from losing their central vision by stopping it early. And I do agree with you that the jury is still out whether it's actually causative or not, because not everybody who's on high dose for many years end up with maculopathy. In fact, I don't think the incidence of maculopathy from Almiron is as high as even plaque renal toxicity. I think it's actually not that high, but I think still it's worthwhile keeping our lights up there, thinking about it as we see these patients.
Thank you.
Caroline,
Thank you.
You had any quick Caroline, you had a quick comment?
I just had one more quick comment. If Judy goes back to her OCT, I know we have a lot of people interested in the choroid in this panel, and this patient has very thin choroid, and we might find that there's certain things that predispose patients to have this toxicity. I guess Judy will have to tell us next year.
Yeah, I think it's,
you'll
we would
see a
like to see
paper
the
soon.
biomarkers, right? You know, what kind of
You'll see a
biomarkers
paper.
predispose certain patients have toxicity while others have been on it forever and ever in high dose and they never have toxicity. So yeah, I think we do need to know, you know, whether it's a cumulative dosage, whether it's something related to their BMI, whether it's related to the choroidal thickness. I think there's still a lot more that we need to learn.
I think we should be moving on to the next case, but just I wanted to make a comment that this is something very serious because there are many lawyers and the law firms who are really hunting for the doctors who have prescribed this. And I had a conversation with our urologist, and overall, the fear is that, means you guys will be surprised if you Google it, it clearly says the doctors were aware of this toxicity and they still never informed you. And patients are really upset, and there are a lot of lawsuits going on this. So we really have to learn about this.
So
Thank you so much.
Can it be told prior hand before starting that you may develop?
Because, you know, Dr. Verma, we really do not have any conclusive causal relationship. So you will see that there is a recent JAMA editorial commentary which really questions the association and the long-term progression in spite of stopping the drug. And there are a few papers, I was going through the literature, and there are a few papers in the urology literature which questions this association. So we should be definitely saving our urology colleagues and not putting them into trouble, because this could be really dangerous to all of us.
Okay.
Oh, so I have a question here to Judy. When you have a patient like that, would you tell a urology colleague to stop the medication or reduce if the patient is on a very high dosage?
So we start the conversation depending on what dosage they're on and what their symptoms are. One patient stopped on her own without any of our input because she was just afraid. And she said, I'll find some other way to manage my painful bladder syndrome. Others, because of their symptoms, they will go down to as low dose as tolerated. And others, the urologist will say, well, let's try something else before we do we come back to the Almiron. So I think, you know, it's definitely a conversation you have to have with the patient and the urologist, get them involved, and then decide what's the best way to control their painful bladder syndrome, because it's quite a debilitating condition.
Yeah. All right, let's move on with Rishi's case. Thank you so much, Judy. It was really nice.